Good morning, everyone. Thank you for joining us this morning. We are the Illinois Family Resource Center. If this is your first time joining us, thank you and welcome. If you are a repeat supporter, we'd like to say thank you for your continued support. Without you all, we would not be able to do what we do. So thank you so much for continuing to support the work that we do. So the Illinois Family Resource Center is a statewide project funded by the Illinois Department of Human Services, Division of Behavioral Health and Recovery. We like to facilitate family engagement across various family and community services within the Illinois Substance Use Disorder Treatment Continuum. So we offer a lot of resources. We do not offer direct services. We offer a lot of different resources on different topics, from problem gambling to mental health to grief, you name it. We probably have some information for you that we can share with you. Oh, it's not moving my presentation. Okay, so I don't know why it's not moving ahead to the next slide, but let's continue. We offer free technical assistance to organizations. We offer translation services if your organization needs translation in with a flyer or a survey that you're giving out to the community. We can help you translate that as well. We offer some of our webinars in Spanish. We do have a training menu that we offer. We list the in-house trainings that we offer. We do work with different speakers, with consultants that they also provide trainings for us. So if you would like to get in touch with us, we will share our contact information in the chat. I am Christina Banda, the education coordinator. I am up in the Chicago area, and Nancy Phillips, who is also on here, is the program coordinator, and she is located in Charleston, Illinois, but we work throughout the entire state. So we travel. We also do a lot of Zoom workshops over Zoom, virtual workshops. So please contact us if you need any resources or if we can work together in any way. Our presentation today is going to be presented by Magdalena Campos. She is a certified national peer recovery support specialist and program coordinator for HLM 180, Heart Life Ministry 180, supporting the Grundy, Kankakee, and Will County recovery-oriented systems of care. With over 10 years of experience as a registered nurse and lived experience in recovery, she works to expand recovery supports, strengthen community partnerships, and improve pathways to care for individuals and families impacted by substance use and behavioral health challenges. Welcome, Maggie. Thank you so much for presenting this wonderful workshop for us. Maggie will be answering questions at the end. So if you have any questions, please save them towards the end of the presentation, and she will be more than happy to answer any questions that you have. For the CEU certificates, you will be receiving them within 2 weeks. You will also receive a Google link for an evaluation. If you can please help us out by filling out that evaluation, that helps us guide our programming and see if there's anything that we need to improve on or offer different services. Please help us by filling out that survey. Thank you so much. And Maggie, it's all yours. Let me stop sharing my screen.
Thank you, Christina. So thank you, Christina, and thank you, Nancy, for allowing me to come here and just give my experience of what happened to me and where I am now. And this is mainly what this is all about, just bridging the lived experience with the clinical and seeing how we can help others to assist them in their recovery for them to choose their pathway to recovery. Like Christina mentioned, my name is Magdalena Campos. I am the program coordinator for HLM Recovery 180. We are servicing 3 counties, Grundy, Kankakee, and Will, and we are the recovery-oriented systems of care through the Illinois Department of Human Services, Division of Behavioral Health and Recovery as well. So Let me share my screen here and I'll start the presentation. I will also say that I do have a degree in nursing. I am a certified national peer recovery support specialist, but I am not an expert. I'm not a scientist or a chemist, or I don't have those degrees. All I can do is just share my experience, and some of my slides will have some information in regards to how the pathways work. But as I share, I'm sorry, as I can't share it here without seeing you guys. As I talk about what's going on, I'll explain how I got that information and where I got it from. Let me see if I can. Okay, because I can't see you guys if I share it this way. Let me see if I can share it another way. Um,
Well,
I
Maggie,
yes.
since we're in webinar format, you won't be able to see
Oh,
anyone's faces.
okay.
Yeah. Mhm.
Got it. Got it. Okay, no worries. Probably even better so I don't get nervous and I don't start, saying, other stuff. So that's a good thing. All right. Let me go ahead and start then. Okay. So here is, are you able to see that? The understanding co-occurring conditions, substance use, mental health, and client-centered care.
No,
Christina,
Maggie.
I'm going to get off for a minute because it keeps coming up and saying something about co-hosting, and that may be stopping her from sharing.
Okay.
Oh,
So
okay.
I will come back on, well, maybe later. It's on my end, I think.
How about now?
Okay. Now we can see it, Maggie.
Okay, awesome. And I can see you guys too. I don't know how I did it, but okay, so let me go back to the previous one. Oh no. And another thing too, I am not very tech savvy, so I will probably stop and do this a couple times before I get it right. So I apologize for that. Okay, are we there yet?
Yeah,
Okay,
we can see
awesome.
it.
Okay. So, understanding co occurring conditions, substance use, mental health, and client centered care. This is how mental health and substance use can interact and shape the client's needs, shape what we need. And I share this. I already told you who I am. I also educate and I'm a facilitator for HERO, which is a heroin epidemic relief organization. And we provide education prevention for those who have experienced opioid overdoses, families. We have a lot of support, so we do all that as well with Hero there. I share this part of my story because people always want to know what came first, mental health or substance use, right? And they kind of go hand in hand. For me, they kind of go hand in hand. And for my experience and the things that I see with the people that are around me, they also go together hand in hand. So are there cases where maybe somebody was curious and experimented with drugs and started getting, addicted to drugs and then the mental health came? Sure. Are there certain types of clients that may have had the mental illness and then used substances to cope with those symptoms and then developed a substance use disorder? Sure. That's kind of how it happened with me. I knew that I couldn't deal with life on life's terms, as we call it. And there was always something that I needed to make me feel okay. And so the first time I drank, I found that. I found that a substance would make me feel okay. It would relieve my intense overthinking. It would relieve my desire to fit in or want to be accepted, or all these insecurities that I carried with me. As soon as I took that first drink, or they all subsided. So for me, that's how it happened. The mental illness came, and then I started using substances to cope with those symptoms. Later on in life, I was diagnosed with different things: PTSD, bipolar 2, major depressive disorder, post postpartum depression. So all those things came later on, and I did start using medications to deal with those symptoms. So the outcome of this presentation is just to see how substance use disorder and mental illness are deeply interconnected, like I just talked about it, and their relationship is complex, bi-directional, which means it goes both ways. Like I explained, it can go either mental health first and then substance, or substance use first and then mental health. It can go bi-directional and influenced by biology, environment, and behavior. So they frequently occur together, which is a co-occurrence. Like I mentioned in the past, I remember trying to get help and seek treatment, and I would call locations and they would say, yeah, we can deal with the substance use, but we don't do mental illness. Or I would call and they would say, yeah, we can deal with the mental illness, but not the substance use disorder. And so it was really difficult for me to obtain any type of treatment because at the time they weren't doing co-occurrence or both dual diagnosis, as they call it. We don't do dual diagnosis, which I was diagnosed with both substance use and mental illness. Now, I think that we are getting that the science of they go hand in hand. So a lot of facilities are being able to treat co-occurrence disorders, which I think is fantastic and give us the ability to recover even better. So people with mental health disorders are at a much higher risk of developing a substance use disorder and vice versa. According to the Cleveland Clinic, studies suggest that about 50% of people who experience a substance use disorder during their lives will also have mental health disorder. And again, vice versa, right? Because it goes both ways. So here is where I am not a scientist. I am not a neurophysicist, although my son is going to school. He's trying to obtain his PhD in neuroscience. So he helped me a little bit with some of these slides because again, I don't know. I do know on a biological sense what the pathways are and how it works because of my nursing degree. But as far as getting more into it, I think there's experts. But the only thing that I want you guys to take away from these slides is that they share brain pathways and genetics. So here we see that the similar regions of the brain where the reward, stress, and impulse control, the neurochemical pathways, dopamine, serotonin, GABA, and genetic vulnerabilities. So this means that a person who is biologically predisposed to anxiety, depression, or trauma-related disorders may also be predisposed to addiction because again, they share the same brain pathways and the genetics too, right? I can't get rid of some genes and keep some genes. I have both of them. So substance use disorder and mental illness often occur together because they affect and are affected by the same brain regions, neurotransmitter systems, and genetic risk factors. And that's what I want you to take away. Here we see some of the shared brain regions. We see the VTA, which is the ventral tegmental area, the nucleus accumbens, and this is where the control of motivation, pleasure, reinforcement, habit formation, this is where those pathways, that region where all this happens. And mental illness link, well, we know that we can have depression, anxiety, PTSDs. If it's dysregulated or it's blunted, this is where we're more vulnerable to seeking artificial reward through substances. So, not to say that I am against any drugs like SSRIs or any drugs that help that, because there are some people that do have a chemical imbalance and may need some medications to regulate that chemical imbalance. I think that with the proper evaluation, with the proper interventions, with the proper psychiatrist, psychologist, counselor, all that is possible, but we need to really pinpoint what's going on and address that in a good way with professionals, seeking professional help. The substance use link here is drugs are hijacked the reward system by releasing large amounts of dopamine, creating intense reinforcement that leads to cravings and compulsive use. So this is when we self-medicate, right? I self-medicated I didn't know how much I was taking, how much was needed. I was either taking too much or too little. And I dysregulated this area of my brain, right, with the illicit drugs, as to where, like I mentioned before, if we seek professional help, a doctor or a psychiatrist is going to see how the medication is working, maybe titrate the dosage and see exactly what's needed to be able to balance this region or any region of the brain. Here we have the hypothalamic pituitary adrenal axis, and this is the emotional hub. So this is detecting threat. It's kind of like the fight or flight response, and we've all heard about that. The brain areas regulate fear, anxiety, stress response, emotional memory, and the overactiveness in the amygdala can cause chronic anxiety, hypervigilance, PTSD symptoms, and people with substance use disorder are heightened. Their stress activity is heightened and more likely to use substance because of this. I A while back, I was working at a hospital, and I would see that pediatricians were now ordering to see exactly the hormone levels that these kids were having, because we know that hormones are associated with the fight or flight response. So they wanted to know exactly what their hormones levels are, which I think is a great idea. It's great to see, because if somebody is in constant fight or flight, their hormones levels are going to be dysregulated. And so by looking at these hormone levels, then we can see why. Why are they being dysregulated? What's going on at home? Instead of just giving them a pill. And we saw that a lot with kids that were being diagnosed or misdiagnosed with ADD and ADHD, and we're just given this pill, right? You just give them a pill and it's going to take care of it. Well, there's a lot of people that I know in recovery that that's how they started with their substance use disorder. As children, they were given medication to cope with these symptoms, and unfortunately they started abusing the medication or resorted to other medication or illicit drugs, and it caused substance use disorder. Again, not to say that medications are not good. They are, when used properly, when used under the guidance of a doctor, a psychiatrist, and we're following up. Yes, they're great. Medications can be great to balance that chemical imbalance, but it's when we stop doing those things, when we stop following up with the doctor, that it can cause certain problems. So impulse control system, here the prefrontal cortex is the one that controls executive control center, right? That controls our decision making and how we're judging stuff, the self control, the long term planning, and for alcohol, with alcohol, it's pretty much the first one to actually stop functioning properly. So that's why we see a lot of people that have DUIs, me myself included. I had several DUIs because alcohol was the first thing that I started using to cope with some of my symptoms. And that decision making were not great decisions. I was making horrible decisions. And so we see that this can affect the impulse control and lower impulse control biologically at higher risk for addiction. And again, this is what happened with me. The more I used alcohol, the more I needed. And then I resorted to other drugs, and it really caused a snowball effect. So again, this is just a shared of neurochemical pathways. We know that dopamine is good, right? It rewards, it gives us motivation, it's pleasurable. We want dopamine, but we want to do it in a healthy and normal way. We know that with depression, you have the low dopamine. With ADHD, you have the dopamine dysregulation, and drugs flood the system with dopamine. So if somebody is experiencing depression, low dopamine, and they use an illicit drug, like let's say cocaine, and all of a sudden you have this flood of dopamine coming in because of the cocaine, it's the person's going to be like, yeah, this is great. I love this. I'm going to keep doing this, because it provides a very good feeling. But again, we are, unfortunately, with illicit drugs or with prescribed medications, if not used properly, if not used under the guidance of a psychiatrist, we can't dysregulate this more and cause more problems. So this is where we have to be real careful. If someone has already had a dopamine imbalance, substances may feel disappropriately relieving or rewarding, increasing the risk of addiction. I feel good. I'm going to do it again. And maybe next time, if I do more, it's going to feel better. And so the more we do it, the more my body builds a tolerance towards it and the more I need. So it's, again, that snowball effect. Serotonin. So with serotonin, we know that it regulates mood, anxiety, sleep, appetite. Anxiety disorders is a serotonin imbalance. Depressions, we know it's a low serotonin. Hallucinogens and MDMA affect serotonin receptors. So this is where we just I always would ask myself, like, why are they asking me all these questions when they would do an intake on me, right? They'd ask me about every single drug in the world. Have you tried this? Have you tried that? And it's because they want to get a good sense of why this person is doing what they're doing and how to meet them where they're at and how we can give them different ways to recover, right? Because if my brain is lacking serotonin and it's lacking dopamine and it's lacking all these great neurotransmitters, then there's different things that we need to address so that that person can at least start feeling a little bit better once they come in to receive treatment. So again, they share vulnerability. Imbalances may drive people to use substances to artificial elevate serotonin levels. And then I have a little picture here of how, these neurotransmitters work and the receptors and how everything is functioning. GABA and glutamate. So these are inhibitory and excitatory neurotransmitters in the brain. So the inhibitory neurotransmitters acting like brakes, right, to stop or calm the nerve activity and reduce neural excitability and control the speed of messages between neurons, helping to manage anxiety, stress, and fear. If synthesized from the excitatory neurotransmitter glutamate, and its balance with glutamate is crucial for proper brain function, with imbalances like conditions like epilepsy, autism, anxiety disorders. So again, anxiety and PTSD, underactive GABA system. Alcohol, benzos increase GABA temporarily, right? And that's a key word right there too, temporarily, because again, all these medications that we have are great when they're prescribed to us, but this is a temporary fix to what really needs to be fixed, right? Why do I need to use substances to be able to feel better? Is it a chemical imbalance? Or is it because I need to do some things internally to be able to start recovery, or both, right? Maybe it's a little bit of both. And we just need to address these things so we're able to give people a better understanding and a better way of recovery. Chronic drug use suppresses natural GABA and destabilizes glutamate. People with anxiety or trauma may use depressants for temporary relief, but develop dependency as the brain loses its ability to calm itself naturally. Genetic predispositions, and genetics are so complex. I don't even know the start of genetics. It's something that's, I'm grateful for people that do it because they are very knowledgeable and very smart. But the one thing that I do know about genetic predispositions is that it's carried, right? It's carried into the DNA. And the example that I give is it also can affect people in different ways. Both my parents were alcoholics, so in turn, that genetic predisposition was already there. And then you add on an environment that was not very healthy, and also the my parents not having a healthy relationship, right? And my parents did the best with what they have. I give hats off to them because they did what they needed to do with me and with with themselves. But there was things, right? There was things that happened to me that formed and shaped me to who I was as an addict and who I am now. But now, in turn, I have two adult children, both boys. Both have the same parents, right? Mom, dad. One, I can see the predisposition of the alcoholism developing. The other one just doesn't care for alcohol or drugs. He may drink a glass of wine when he's sitting down eating dinner, and that's it. So same family, they went through the same things. They have similar genetic predispositions, but for whatever reason, sometimes it just doesn't happen that way. We just don't know, but we do know that this genetic predisposition will be there. And like the slide says here, it accounts for 40 to 60% of the risk factor for both mental illness and addiction. This influences how somebody is sensitive to stress, how their brain processes dopamine, what their impulse control is, what their emotional regulation is, how strongly they experience reward, and how quickly they metabolize substances. Again, these genetic predispositions are here. There's some examples. I put this slide in there just for you to have an idea of what they are and how it breaks down. And you guys could read this. If you guys want these slides, I'll be more than happy to share them with you. Christina has a copy of them, so she can also email them out to you. But all this, so it says here, examples of shared genetic risks, and it gives all the examples. It gives what they do, who they are, all to say that family history of depression or addiction increases vulnerability due to inherited stress response patterns and neurotransmitter functioning. So again, we have the predisposition of genetics there, and it's kind of saying, yeah, you have an increased chance of also developing this. Another key point that I take, right? I'm in recovery, and so I do some things in recovery to maintain my recovery. One of the things that I do is I instill those things in my daughter. I have a 7-year-old daughter, and I know that she is predispositioned to be an alcoholic or an addict because of her genes. Both parents are alcoholics and addicts. And so the things that I do for me, for my recovery, I also share them with her in a way where I meet her where she's at as a 7-year-old, but teach her to include these things in her life so that she can start developing some recovery before it happens. And that's kind of like prevention, right? Because I know she's already predisposed to possibly being an addict or an alcoholic. I'm not blind to that. But what can I do so that she is aware of it and that she knows how to deal with it in case she has some of these things that I had as a child that I didn't know how to deal with? So praying and hoping that she doesn't turn out to be an alcoholic or an addict. But if she does, at least I've instilled some of these things in recovery in her so that she's better equipped. So putting it all together, because substance use disorder and mental illnesses share the same brain circuits, right? The same neurotransmitter systems and the same genetic risk factors. A person who is predisposed to anxiety, depression, ADHD, trauma-related disorders, or mood instability is biologically more likely to develop a substance use disorder. So again, the same vulnerabilities is more susceptible to mental illness, make them susceptible to addiction as well. So again, mental illness can lead to substance use disorder, right? Many people use substances as ways to cope with symptoms such as anxiety, depression, PTSD, bipolar, ADHD, sleep issues, also known as self-medication. As you know, that's how I self-medicated the first time and continue to do so with other substances as my symptoms got worse. And it often leads to dependency. So then my brain developed this, I need this drug to feel okay and continue to live life, or so my brain tells me. And so we rely on these substances for relief. How mental health conditions correlate with illicit drug use? Well, again, same patterns. not rules. People use substances for many reasons. I already explained, maybe just peer pressure, right? There's peer pressure, the wanting to fit in, the curiosity. I want to see what it's like, access to them, environment, trauma history, coping styles, they all play a role. But certain drugs interact with the brain in ways that particularly appeal to or worsen specific mental health conditions. And that's what we're going to look at in the next few slides. So, anxiety disorders, right? We know generalized anxiety, panic disorder, social anxiety. A lot of people with those disorders tend to use these drugs like alcohol because it calms the nerves, but it worsens anxiety over time. Again, the more I use, the more I need, but the worse my symptoms are. Benzodiazepines, misused for rapid relief. Marijuana, especially high THC strains, self medication for anxiety, but may increase panic or paranoia. There's been several cases that I've seen where the high concentrations of THC caused psychosis, and they're linking that. They're linking the high THC strains with psychosis. And there was one incident where a friend of mine in Wisconsin, his son was vaping a high concentrated THC. It's called diamonds, I believe. And he went into psychosis, and he went to a church. He had a gun. This other these other people that also went to church, or they were in the parking lot and they saw him, they saw the gun, and unfortunately they pulled out the gun and killed a young man because he was in psychosis and he was threatening and he had a gun. And these are the things that we need to just take in consideration. Marijuana here in Illinois is legal, right? And we also know that we don't know if the mental health came first or if the substance use came first. However, what we do know is that substances, especially illicit substances, can worsen these symptoms. And so this is what I just want everyone to be mindful of, that we just need to pay close attention to what is being used and how it's being used, and if it's being used under the guidance of a doctor. Heroin and other opioids used to numb physical and emotional tension. So these temporarily reduce fear and panic by increasing that GABA or suppressing the stress response. But again, as soon as they wear off, there's a need for more. Depression. So we know that some substances like alcohol, opioids, cocaine, methamphetamine, and marijuana are used for depression. Why? Because often the low dopamine and low serotonin, and people seek drugs that lift the mood, right? They want to create a stimulation. They want to provide escape from emotional pain, but these substances will deepen the depression by disrupting natural neurotransmitter cycle. So with alcohol, I can remember drinking, having a great time and having a ball, getting home, crashing, passing out. But then the next morning, the feelings of guilt, shame, and remorse, and what did I do? Or I don't remember what I did. And all these things just got worse and worse and worse. So then what did I do? I went out again and I drank more because I didn't want to continue having these symptoms. And so this vicious cycle continued over and over. And for me, I started using opioids on top of that because uh, I felt the first time I tried an opioid, I really enjoyed the feeling, the euphoric feeling that the alcohol was no longer numbing. So then I substituted an opioid for alcohol. And, opioids are very highly addictive. And I always say alcohol was my first love, but opioids dropped me to my knees because that's what ultimately got me to the worst I had ever been. So PTSD and trauma related disorders. Here we see also that some of these substances are similar: alcohol, marijuana, opioids, stimulants, right? And it says here the alcohol dampens the nightmares, right? The hypervigilance. The marijuana can calm or the thoughts or hyperarousal. Opioids, again, they numb that emotional pain. That's what happened with me. I was just numbing it. Stimulants to counter emotional numbness or fatigue. So sometimes that feeling of like there's nothing, right? Hopelessness, nothing. Well, with the cocaine and the meth, it stimulates that. So some type of, again, artificial hope arises because of the use of this illicit drug. So, why? Well, they shut off intrusive memories, they reduce emotional overwhelmness, and provide temporary escape. And here, this is a very good thing to remember that PTSD is one of the strongest predictors for substance use disorder. ADHD. Stimulants, marijuana, and nicotine are commonly used substances. Well, why? They improve focus, reduce restlessness, momentarily slows down those racing thoughts. But after the crash, it increases irritability, impulsivity, and addiction risk. Bipolar. Stimulants, alcohol, marijuana, hallucinogens, these all, like it says on the slide, they relieve some impulsivity, risk taking, sensation seeking, and reduce judgment. But again, they can escalate to mania. Depressants can worsen bipolar depression. Schizophrenia and psychotic disorders, I think these are the most complex ones. I think these are really the ones where I think we need to be just a little bit more aware of what the symptoms are because it can be, like I said, very complex. So, marijuana, stimulants, hallucinogens, and why will increase the substance can increase psychosis, trigger hallucinations or delusions, disrupt dopamine regulation. Research consistently shows cannabis is strongly associated with early onset of psychosis in vulnerable individuals. Borderline personality disorder. Um, Substances used: alcohol, opioids, stimulants, marijuana, and people often struggle with emotional instability, intense stress, fear of abandonment, impulse control issues, and the substance can be a way to regulate these overwhelming emotions. Social anxiety disorder. So again, alcohol, and this is, I think for me, this was anxiety was something big for me, right? I had my first panic attack. Let's see, at the age of 30, I believe it was 20, 29, 30. I remember my son was about 6 years old, and I remember feeling overwhelmed and I didn't know what to do. I didn't know what was going on. My heart was racing and all these feelings and emotions. But as soon as I would take a sip of alcohol, it would calm down and I would attribute it to, oh, it was just a hard day, or I use alcohol to relieve my stress. This is how I de-stress. But then they kept this again, the symptoms can get worse and worse and worse, and I didn't want to use more alcohol because I knew there was already consequences from alcohol. I had already gotten 2 DUIs by that time. So I had these consequences from alcohol consumption. So my first panic attack, I went to the hospital. They told me it was a panic attack. It was my first psychiatric stay. I stayed there for a week and they diagnosed me with panic disorder and anxiety disorder, and they gave me Xanax. So Xanax, I think it was 0.25 milligrams every 6 hours as needed for anxiety. And again, I started using the Xanax and it felt good and it calmed me down, but then I felt like I needed more. So I got the prescription increase and then I needed more and more. So here's the thing, right? Like I needed to find out what was going on with me, inside of me, that was causing this anxiety, this depression, this emotional overwhelmness. And I kept using drugs and alcohol and substances to numb it or decrease it, but again, as soon as these substances subsided, I still had all that going on within me, myself. So I had to look inward to be able to fix some of that stuff, to be able, again, to deal with life on life's terms. It's not easy. It doesn't happen overnight, but it's definitely been the most valuable and the most rewarding thing that I've ever done in my life as a result of a 12-step program and me just building on to my spirituality. I've been able to wean with a doctor, with the help of a doctor, wean off all medications. At one point, I was on 7 psychiatric medications, but I have been able to wean all those medications because, again, for me, and this is just my experience, I I do know that there was always a mental health disorder within me, and I just started using substances to try to deal with that, was with what was inside of me. And once I started fixing the internal, then I didn't need the external. I didn't need these drugs and alcohol to deal with that. So I'm grateful for that. And like I said, this is just my journey. But I do remember that this social anxiety would always come about, and as soon as I would take one drink, that it would help me. OCD, so we see again here that these are the most common substances used: alcohol, marijuana, hallucinogens, to some misuse in hopes of resetting intrusive thought patterns. Individuals attempt to manage intrusive thoughts and compulsive anxiety. So here's a little summary table, and this is just gives you the mental health condition and correlated illicit substance, just to give you an idea of, sometimes people come in with depression or PTSD or social anxiety, and then you'll see what the pattern is of their. We always see alcohol first, right? Well, what did you start doing? Not all the time, but a lot of the time we see alcohol first. Well, why? Because it's socially acceptable, it's legal, and it's readily available anywhere. So we always see alcohol as being the first one. And then you go into your other illicit drugs or some prescribed medications too, right? You're a kid and your parents take you, and the doctor says, okay, well, he's got this, let's try to help him with this medication. And so some medications are prescribed, and we get into that pattern. And again, as we get older, we start to experiment with other drugs, and this is a pattern that you see for people who experiment with these drugs. So again, substance use can trigger or worsen mental illness. It changes the brain chemistry. We all know that the more we use, the more we need, because some of those receptors start to shut down, or the body just kind of takes them away, and it's dysregulated, and we think that we need more to be able to feel the same. So it can lead again to more mental illnesses or health issues. So stimulants can cause anxiety, paranoia, psychosis. Again, alcohol and depressants worsen the depression. Cannabis can trigger psychosis, and hallucinogens may intensify trauma or anxiety. In some cases, symptoms persist long after substance use stops. We all know what trauma is. I think at one point or another, most people have experienced some type of trauma. We do see that with substance use disorder, a lot of the people affected by it, including myself, is childhood abuse or neglect. I also experienced domestic violence. I also experienced community gun violence, loss, grief, chronic stress, and environmental adversity. When I saw that environmental adversity, I remember as a child, I lived in California for a few years, and I was in an earthquake, and that was very scary. That was, it did cause some trauma. And as I think back, that in itself, like, I just see the people that just experienced the tornado in Kankakee, and we work out in Kankakee, and I saw the massive trauma that the people are experiencing currently because of this. And it's going to take years to repair all of that. And it's going to take more years to be able to feel at least better or somewhat back to normal to how they were before that tornado. So all this can contribute to all the trauma that someone experiences. The trauma changes the brain and increases risk for both mental illness and substance use. 75% of people in a substance use disorder treatment report trauma histories. So the statistics here from SAMHSA says that 75% of individuals in substance use treatment report past trauma. And that's a lot. 75% people is a lot. Like, yeah, I experienced some type of trauma. And then I also got to take in considerations, because me included, and some people that I know, that when we're being asked these questions, and I have a lot of shame and guilt, and there's a lot of things that happened to me, and I'm not ready to be honest. And when they're doing this interview and this, this intake, they might ask me some questions that I might not answer honestly, because of everything that I'm carrying. So these numbers may be a little bit lower than they really are. People with PTSD are 2 to 4 times more likely to develop a substance use disorder. So here we get this from the National Center for PTSD, U.S. Department of Veterans Affairs, that individuals with PTSD are 2 to 4 times more likely to have a substance use disorder. And we see that a lot. Like our vets come home, or even when they came home from Vietnam and they started drinking or using other drugs, right? Because they couldn't deal with this internal, they didn't have an outlet, they didn't have all the great services they have today to be able to deal with this. Um, and it was a shame, right? A shame. Like, why are you doing that? Why can't you just get over it? I think for men, it was a big shamer. Like, you're a man, take it. How are you? Why are you doing this? So again, it's. I'm just glad that this field has come a long way, even within the last, I would say, 5 to 10 years. I've seen a lot more progress in this field than I have in the past. And I'm just super proud, because I do feel that the more we talk about it, the more we express how we feel, the more we're honest about it, the more vulnerable we become and really say what we're feeling. I think the better chances we give others to have a voice and to be able to start the recovery journey. About 46% of people with substance use disorder have lifetime PTSD, and this is from the Journal of Substance Abuse Treatment. 70% of US adults have experienced at least one traumatic event. This is from the National Council of Mental Wellbeing. ACEs, we all know what ACEs are, right? Acute childhood experiences. So these increase mental illness and substance use disorder 5 to 10 times more. So individuals with a 4+ ACEs are 5 to 10 times more likely to develop a substance use disorder, and 2.5 times more likely to develop depression. This is through the CDC. I know that there's a lot of ACEs studies out there, and they give a lot of great information. Um, this is just some of the information that I found, but if you go out there, and they can give you lots and lots of information. And I know that we've been very trauma informed. There's been a lot of trauma informed trainings and education, which is very, very beneficial to this field. Again, this is something that the more we learn, the more we find out, and the more we're equipped to better help those to start recovering. Up to 60% of teens in substance use treatment meet criteria for PTSD. These are high numbers. Survivors of physical or sexual abuse are 3 to 5 times more likely to develop addiction. So I think this is the one. This is maybe it's the next one. There's one where it says that people incarcerated who were incarcerated have also really increased high ACEs, and have also experienced some type of sexual or physical abuse. Environmental and social factors increase risk. So we know that family history, we already talked about genetics. We know chronic stress. So my environment, poverty, is there, do I have a support system? Do I have resources available? How readily available are those resources? Unstable housing, peer influence. So these factors can make both disorders more likely to occur together. They both require integrated treatment. So we know that we can help these with counseling, again, medication when appropriate, peer recovery support. I was just at a peer recovery support event last Tuesday which somebody said, peer recovery is the way to go. It's the way to the future, because I think, it's great that people go into the field of psychiatry and they have this degree, and including my son, right? My son has the lived experience of seeing his mother in addiction, but he went and he wanted to pinpoint exactly which neurotransmitters, or which neurons caused addiction and mental illness, and that's his goal. That's what he wants to do. That's his goal in life. He wants to pinpoint exactly which neurons in the brain cause addiction and mental illness because of what he saw with me. But he always says, Mom, he's like, I can research and I can educate myself and I can do all this, but I don't have the experience that you have. And you can reach people in a way that I can't. And so together, right? Because I always say we can do this together. You do the research, you get the knowledge and the wisdom, and I can give them the experience that I had and how I recovered. But I think together we can come together and just give people a better chance of recovering in a more broader ways and pathways to recover. Harm reduction tools, that's a good one too. Family support system. So in summary here, substance use disorder and mental illnesses are correlated because they share the biological roots, right? The same ones, environmental risk factors and behavioral patterns, and each one can worsen or trigger the other. And that's it. You know what? I'm gonna go real quick over the. Do we have to? What time do we have till, Christina? I think it was
It's scheduled until 11:30, Maggie.
11:30. Okay, so I'm gonna
Mhm.
run real quick through the other one, which is the integrated lived experience. That one's really, really short. Okay. All right. So this is integrating lived experience into clinical practice. Again, that's who I am. So here we see that SAMHSA defines lived experience as the personal knowledge and understanding gained from direct involvement in life events, especially mental health, substance use, and recovery, emphasizing self determination and empowering individuals with firsthand insight into behavioral health systems for better policy and practice. It's about a person's unique understanding of their own experiences, choices, and perceptions vital for improving services and fostering recovery. I always say I have my lived experience and it can help somebody, but they don't have to take my path. I chose a path and I'll let people know which path I chose, but it doesn't have to be the path that you choose. Now, if you choose that path, if you make that decision, I will help you and guide you through that path. And so it's a way to, again, like it says, to empower individuals. I think that's where, for me, it sticks out the most, empowering individuals with firsthand insights into behavioral health systems. So why lived experience? So again, we bridge that trust gap. So my experience was that psychiatrists were always telling me what I needed to do, what medication I needed to take, and how I needed to do it. And so I always felt like, oh, well, I want to have my own voice. I want to be able to choose my path. I want to be able to do that. So I felt like I was always being told what to do until somebody who was a peer sat next to me and said, well, I was in your same shoes, was doing the same things, but this is the way I chose to live. This is the way I chose to change. And this is my path to recovery. And so I saw the difference. I saw the change, and her coming along me, or next to me, and showing me that path was what really opened my eyes and opened my mind to say, hey, maybe I could do this. Maybe if she did it, I can do it too. Staff with lived experience reduce power imbalances by showing recovery is possible. Clients often feel seen rather than assessed. Normalizes the recovery process, helps clients understand that setbacks are part of healing, not failure. That was huge for me because I'm a perfectionist. On top of that, when I fail, I really get down on myself. But then I have the perception that others are also judging me and telling me that my failure is the end. And for somebody to say, hey, you know what? I failed too. But guess what? I got back up and I kept doing it. And that was powerful for me. Like, okay, I'm going to fail. I'm still going to fail. Even in my recovery, I'm going to fail. In the future, I'll have more failures. But it's the getting up and trying again. And what am I going to do different? What am I going to do to improve? Maybe I might not get it right again, but how am I going to improve? What am I going to learn from this? And that was really powerful for me too. Reduces shame and self blame through shared understanding. And here are some of the lived experience, how it strengthens the engagement. So, again, it builds that authentic connection. Shared experiences foster empathy. They're more likely to open up and feel understood. The client believes that the helper gets it, right? Oh, she gets me. She understands where I'm coming from. The hope increases. It demonstrates recovery as achievable and sustainable. Seeing someone who has navigated similar challenges creates credibility. Like if she can do it, I can do it. It improves communication. Often do I know some terminology, some medical terminology? Sure. I was a nurse for more than 10 years, right? I know some medical terminology. I know how to say things, but not necessarily do I have to use that terminology. I want to use terms that I can relate with whom I'm talking to, right? So I meet people where they're at. My clients, I talk to them in slang, and just so they can feel comfortable so that I can build that trust and build that rapport. Peer informed link, oh, we talked about that, helps interpret client behaviors through a trauma informed lens, reduces mislabeling of survival behaviors as non-compliance. That was huge too. Every time somebody would say, well, why aren't you doing this? Well, how come you're not doing this? And so there was these things that my survival mode techniques sometimes didn't allow me to do things that I wanted to do. I always talk about self-sabotage. I had a I had a fear of success, right? So I would self-sabotage, and I would, before I achieved something, I would either show up late or not show up at all, or say, oh, that's not for me. Nope, I can do better, or whatever it was. I would just self sabotage because I had a fear of success. And so these things, people would say, well, you've gotten so far. How come you just don't keep going? You've done this. Why do you backtrack? Why do you do this? Always wanting to understand why I didn't keep going, or I would backslide. And it's not because I wanted to be this horrible person. It's just that I had these instincts that I had developed as survival skills that just I had to work on internally. Complementary, not replacement. So it enhances clinical care. Like I said, I give my hats off to those who go into the field of psychiatry and get their degrees and get are book smart. And I think that's great because we need people like that. We need people to understand and get the knowledge from. But then we can also enhance that by being able to bridge that gap with our lived experience. So we know who each person does, right? But we can come together and be able to help the client better. Ethical and trauma informed use experiences are shaped purposefully, not therapeutically reversed. Interdisciplinary collaboration, peer support, especially family peers, recovery coaches. We all work alongside clinicians. We all work together. Teams benefit from both clinical expertise and experiential insight. Now, I'm part of this parent. It's called a peer parent program at school, at my daughter's school, that actually I helped develop, right? Because there was a lot of kids that were not coming to school, and they wanted to know why these kids were not coming to school. What can we do for the kids? Let's, give them incentives. Let's give them awards if they come and have perfect attendance, which is all great. I'm all for it, right? If you work hard and you get there every day, great. They should receive an award for doing that. However, let's also find out why they're not coming to school. What is it about them not being at school? Is it something at home? Or, is it something going on with their parents? Can we help the parents? Can we assess the needs of the parents? Because ultimately they're children. They're just being told what to do by the parent, and the parent is guiding them. And the one that's guiding may need some help. So we developed a pilot program. We're gonna see how a peer parent can help another parent to be able to get these kids to school. So that's how it works. We just come together to be able to assess the situation and come with the professionals, right? We're working with the superintendents and the principals to be able to see how we can help. System level benefits, increase client engagement and retention, reduce no show rates and early dropouts, stronger linkage to care and follow through, improved outcomes for marginalized and justice involved population. I think that's a big one too, justice involved population. It's not only do people with mental health and substance use have this stigma on their backs, right? That they're not good and they're not worthy, and they have all these things going on already. Now you have somebody who's justice involved and also has um, a record, right? It's a physical record that when it gets pulled, when they do a background check, they see it. It's attached to them. And so it's like a double whammy, right? And so these people really are just, they don't feel that hope. They don't feel like they can do anything. A lot of people that I've worked that are just as involved, including myself, I was just as involved. And at one point, I thought, I will never get a good job. I am never going to be able to do things in this community. And I thought these things. I really thought this was going to happen to me. And again, recovery is possible. And I always say, if I can do it, anybody can do it. I'm grateful that I get to work in the spaces of recovery to help others. I'm grateful that I get to do webinars like this that I never thought I would ever do. I'm grateful that I get to go work with the community and police officers and fire departments and politicians to be able to make some changes. But here's the thing, like, we got to give that hope. And if it wasn't for that person, that recovery coach that sat next to me and said, hey, you know what? I recovered and I'm here. Let's see how you can recover too. If it wasn't for her, I probably wouldn't have that hope that I have today. So again, when lived experience is integrated with clinical expertise, care becomes more human, accessible, and effective. Recovery-oriented systems thrive when professional knowledge and lived wisdom, when they work together. Again, it's about working together. Um, there's a lot of people in the field that have lived experience that I worked with and have degrees, which, wow, that's amazing, right? Like, I can go back to school and I can get this degree and I can have my lived experience. But again, I also work with individuals that had that sympathy for people like me and said, man, I want to help her. I want to help them. What can I do to help them? I don't, I want to be able to help them. And they go to school and they get the degree and then they come back and help. That's amazing. And what we can do is we can help each other. We can help each other be able to provide those a better way of recovering. Okay, that's the lived experience one. If anybody has any questions, I'll be more than happy to address any questions. If you have any comments, if you have anything that you would like to say. Do you want to do a breakout room, Christina, or do? Oh no, okay. Here's a question, Sonia.
Hi, not a question. Just want to say thank you for sharing your story. I'm a peer specialist in VA, and I know it takes a lot to be able to just be vulnerable and let people know your experience. So I just wanted to say thank you for sharing.
Thank you. I appreciate you.
I was muted. Any other questions or comments for Maggie? We will be sending the slides out to you with, along with your certificate, your CEU certificate in the next couple weeks.
I've got a question. Having met Maggie and just really been so glad that she's joined us in doing some of this, where do you see yourself in 3 or 4 years from now? What do you want to be doing with all this that you have learned?
That's a great question, Nancy. To be honest, I want to continue in this path. I want to be able to help others, and wherever it may be, I think as long as I keep learning, that's a key word for me, learn. Because from every experience, every interaction, everywhere I go, I want to keep learning. And my son told me the other day, he's like, Mom, you're not that old. You can go back to school. And I'm like, oh, maybe. So maybe I'll see myself getting some type of degree where I'm able to utilize it again to help others understand the disease of addiction, the disease of mental illness, all that, somewhere where I can really go into and help others. Um, so wherever that is, Nancy, I just hope that I'm able to be of assistance.
Well,
But I
listening
do. I'm sorry.
I was just going to say, listening to your history and listening to where you are today and knowing the group that you're working with, which is a tremendous group as far as I'm concerned. I just wondered where you saw yourself going because that's a lot to bring into the field and we need it. And I've been in this field many years when it started out being people with lived experience. And then suddenly everybody had to have all these degrees for 20 or 30 years. And the fact that we're getting back to this, I love seeing it promoted. And I just really appreciate you doing that and wondered if it was going to continue.
So if you would have told me, I started my recovery journey May of 2021. So this year it'll be 5 years. If you would have told me in May of 2021 that I would be doing this, I would have laughed at you because I did not believe it. I wouldn't have imagined that I would be doing this. So I'm very grateful that I get to do this. But when I started my recovery journey and as I went, just the opportunities and the people that I've met and my director Nisha Stringfellow giving me an opportunity and just taking off from there, right? Just pouring out into the community and to the other communities has given me this, and I always say this in this high, right? Like this high, I always say, when I was getting high on opioids, I had this euphoria and I had this feeling and I loved it, right? But then the drug wore off and then here I go, I needed it again. Well, this high that I get from helping others, it's always there. It's always accessible. It's doing good for others, right? And ultimately it's like a full circle. It repays me back. Like somehow or another, like I get to either excel in my career or go other places, but it's just this constant of wanting to help, getting the opportunity to help, helping those, and then helping myself as I'm doing it.
Yeah, that's great. I thank you.
Well, thank you. You're welcome.
It's too
Yeah,
bad
I
that
also, well, I
I was
also
just gonna,
wanted to go ahead, Nancy.
the only thing I was going to finish up, we need to be raising our hands like crazy. The, the only other thing I was going to say is I would be interested in knowing how many people that are on here are peer recovery specialists or family partnership professional specialists or somebody that's in that role. But if you are, stick it in chat real quick because I would be interested in pulling some of that data off when we're done.
Yeah, that would be a great question. How many people on the current call have lived experience and or are peer recovery support specialists and or are above, right? CADCs and, maybe psychiatrists, doctors, directors, all that good stuff.
Okay.
Oh, Natasha, I know Natasha. She is a CRSS from the Recovery Community Center of Joliet. Hi, Natasha. And a lot of the people that I work with that are in this field do have lived experience.
Oh, right.
I have a really good friend. So same thing. She came into recovery. She found recovery. She went back and she got her CADC and now is working in the field as a CADC with lived experience. So
Right.
yeah, we have Samantha here with lived experience, almost CADC. All right, keep going, Samantha. And then Angela has lived experience with CADC. That's awesome, Angela. Thank you.
Yeah, that's good to know because I think that for our field, this is my philosophy. I've been in this field 40 plus years, and I've seen it go from the people with lived experience because they were the only ones that would work with other people 40 years ago through you had to have a degree in order to work in the field to back to really recognizing that the value of that lived experience. It's just kind of interesting to see it go on, and that's the direction I think it ought to go. I
Mm-hmm.
mean, I think that it's going to be what keeps our field going and building, and it's going to keep supporting the Ross councils and the
Absolutely.
RCOs. So all of you that are out there doing it, all I've got to say on this April day is thank you. And
Yes.
I'm going to butt out now.
I just wanted to add, Maggie, that thank you for sharing your story. It really does make a difference when you share your story with your clients, because they see that you're just like them, and they don't feel that shame or that like stigma. I also wanted to applaud you on what you do with your daughter. Giving her the tools to like educating her, because you do know that she does run that
Yes.
risk. So
Mhm.
giving her the tools, I wish that more parents, more caregivers would do that, because even in my own family, I've, seen, alcoholism, and it's like, it's okay. We don't talk about that to the children,
Mhm.
they don't need to know. And I think that's putting them at a disadvantage, right? Because it's like if the more you educate them, you prepare them, you give them the tools, you talk to them about what is going on. It's preparing them so that they're equipped with those skills. Instead of just keeping it away from them, and then the cycle just continues and nobody wants to talk about it. So thank you for sharing your story. Thank you for sharing what you do with your daughter. It's great to hear that. I wish more people would do that.
Thank you. And I always share this too. I see the difference that it makes with my adult children and with my daughter, right? So my son in California, he's at the University of California, Irvine, getting his PhD in neuroscience. Very smart boy, but he went through a lot with me. He is the one that found me overdosed the first time, so he had to call 911, and he went through a lot. Um, but I don't know if it's the fear of like I don't want to be like my mom, so I don't want to, you know, possibly do anything that I may end up like that. But he really focuses on like his school and which is great, right? Like I'll rather have him focus on that than anything else. And then I have my son, right, my middle son, who is 23, and he drinks here and there, and he goes out with his friends, and he made me a grandma. He's the one that made me the grandma. He was only 20 when he made me a grandma. But I see the differences, right? Like same kids, same environment, saw the same things, same genetics, just two different, right, perceptions. And it's like the damage was done. That's how I always feel. The damage was done. I made my amends. I try to do the best that I can as a mother today, but the damage was done. And so with this one, my daughter, right, I'm like, oh, we were at a restaurant before, and she comes over and she whispers in my ear and she's like, Mom, they're drinking, because she's never seen me like drink or use drugs or nothing. So that's abnormal to her. Like, people are drinking, and that's abnormal. As to when I was growing up as a child, everybody in my household drank, like uncles, aunts, grandpa, grandma,
Mhm.
cousins, they all drank, right? So that was normal to me. So I saw it as people who didn't drink, it was abnormal to me. And so that's the two different perspectives, right? Like, that you see children growing up. And like you said, as parents, we do the best with what we have. I never woke up one day and said, I think I'm just going to have my kids find me overdosed in the middle of the bathroom. I didn't wake up saying that. But at that time, I was sick. My disease had overtaken my brain. And that's what I was doing. But never did I want to harm my kids. We just do the best with what we have as parents, and just keep getting better and better and better. Hope to keep getting better. That's one of the things that I emphasize to the girls who are in rehab, right? Like, when they get there, and I was one of them. Like, I had to make a choice of whether I stayed with my child or do I go to rehab. Like, that's my choice, right? What do I do? And I made the choice to go to rehab. So I tell these girls, like, take it as a vacation. You have 28 days. Your kids are taken care of. If an emergency arises, I'm sure you guys will know. Take it as a vacation to be able to focus on you, to be able to recover, so that when you get home, you're able to be the best mom that you can to that child, and start your recovery so you can stay with that child. And just that's what helped me, that foundation of being able to help me first. I need
Mhm.
to help me so I can help others. If I'm not good, my kids are not good. If my foundation is not good, I'm not going to be able to pour onto my kids' foundation. And I really emphasize for women. I know that you and Stepping Stones here in Joliet are the only, I believe, right, the only facility that has a women and children's recovery home. So Stepping Stones is still in the process of getting their license, but that was huge. Like, just having a place where you can interact with your child and live with that child, and be able to just not have to make that choice of, do I go to treatment and recovery and seek recovery, or do I take care of my child, which is huge. And you know what? Maybe even some parents too. I know some single dads out there that are in recovery that have gained custody of their children and that are doing the single parent thing. Shout outs to them, because as a male, they too have those choices, right? Like, I have a friend who, unfortunately, his kid's mother, did not choose recovery, but he did. And so he started recovering, and he got custody of his son, and he has full custody of his son now, and he's doing it. So shout out to the guys who step up also and do that. But it's hard. It's really hard to be able to make that choice. And I just think that the more we learn, the more we voice this, the more the people that are able to help start helping to make these things possible.
Again,
Yeah.
thank you, Maggie. Anybody else questions or comments for Maggie? If not, thank you for joining us. Check out our website for a listing of the future webinars that we have coming up. We do have another one this month, April 21st. And then we have two more in May and two more in June to finish off this fiscal year. So if you want to and have time to join us, please, we encourage you to keep on supporting us, because again, without you, we would not be able to do what we all do for our communities. So thank you so much for joining us. Hope you have a great day. You will be receiving your CEU certificate along with a copy of the presentation within the next 2 weeks. If you do not receive it, you know, in the next couple weeks, feel free to email myself or Nancy so we can check on it. But thank you so much for joining us. Thank you again, Maggie, for sharing your story, and for presenting for us. It was a pleasure and it was a great presentation. Thank you so much, everyone.
Thank you.
Bye bye.